recorded. Here we go. So next month for our Wall Family Session, we are going to have our yearly tradition of showcasing our own Michigan medicine students and trainees with work that they've done at the intersection of religion, spirituality, and medicine. So we have 3 of our student fellows presenting and 1 of our former fellows who now is a resident here in OB-GYN presenting their work. And this is work that's been accepted at the Conference on Medicine and Religion. So it's a chance for them to practice their presentation. So please come out and support them. So their presentations will be by Zoom on Tuesday, March 25th from 12 to 1 p.m. Eastern Standard Time. For April, we are really thrilled to be hosting Dr. Matthew Loftus. He is a physician working in Kenya right now and has had writings published in the New York Times and the Atlantic. And he will be talking about how his global health work is driven by his faith commitments. His date, he'll be speaking on April 11th, and we will sort of announce that in future communications from the program. Also of note, he and I were co-authors on an op-ed that was published in the New York Times yesterday. So if you're interested in reading more of his work, you can find him at the New York Times and the Atlantic. If you aren't on our listserv and want to be, please message me or Adam and we'll be happy to add you. Lastly, I will be speaking at a Rose Mass at St. Thomas here in Ann Arbor on Saturday, March 29th at 4:30. The topic that I've been asked to speak on is physician conscience. Like, what is it? Why does it matter? So please join us. If you want to register, find out more information, please message me. All right, so now on to our main event. So we are thrilled to have Dr. Mark Kissler here from the University of Colorado. So the idea to invite him was given to us from one of our own health, spirituality, and religion student fellows, Anjola, who is on the call today. And Anjola will be introducing Mark and running the session. So now we'll turn the floor over to Anjola, who will introduce himself. So just so you know a little bit about him, and then he will also introduce Mark and run the session. Anjola, the floor is yours. Thanks.
Thanks, Dr. Collier. Good afternoon, everyone. I'm Anjola Onadipe. I'm a 4th-year medical student here at University of Michigan Medical School, and as Dr. Collier mentioned, one of the Health, Spirituality, and Religion Fellows. It's my pleasure to introduce our guest this afternoon, Dr. Mark Kissler. Dr. Kissler is an assistant professor of hospital medicine at the University of Colorado School of Medicine. He holds a master's degree in narrative medicine from Columbia University and an MD from Baylor College of Medicine. And then he went on to complete his training in combined internal medicine and pediatrics at the University of Colorado. He serves on the Academic Leadership Council for the Colorado University Center for Bioethics and Humanities. And in addition to his clinical work and teaching, he's engaged in scholarship on attention, bridging clinical care, systems improvement, and health humanities. And the title of his presentation today is On Attention. So Dr. Kissler, please take it away.
Great. Thanks so much, Angela. Let me see if I can launch the PowerPoint here. All right. Does that look okay? Great. Well, thanks so much. I'm really excited to be with you today. I think this is such a cool group, and there's so much interesting scholarship. I got to listen to some of the previous talks, so a really fun group of people, and it's just a pleasure to be here. This is a topic that's enlivened my scholarly work for the last 5 or so years, and I think it's also really constantly present for me in my clinical practice. So I'm excited to get into it with you. So thanks, Dr. Baruch, Dr. Collier, and Anjola, especially for inviting me. I have no disclosures. I'd like to begin with a quote from Henry James' novel, The Wings of the Dove. This quote calls me back to my narrative medicine training because it was a favorite of one of my mentors, Rita Sharon, as we discussed the role of attention in the clinical encounter. And in this scene of the novel, the protagonist, Millie Thiel, is speaking about a physician who's listening to her. Through her, Henry James says, "So crystal clean was the great empty cup of attention that he set between them on the table. It was like an absolute possession, a new resource altogether, something done up in the softest silk and tucked away under the arm of memory." In this quote, we have both the inestimable value of attention and also a sense of its physicality. There's a way that the attentive listener evokes a great empty cup and gives an absolute possession that can be tucked away under the arm. Often when I sit in hospital rooms, I think about the space opening up in between me and the patient. and the tangibility that something like attention might bring into that space. Something that comes in primary even to all of the technical medical expertise that we bring to bear on a situation. We'll be traversing some intellectual territory in this talk, and I think often it's a good idea when we do that to begin by being grounded in the body, and perhaps especially for those of us whose work as clinicians brings us often into that complex and fragile domain. The words attention and distraction themselves encode physical sensations, distraction being a pulling or a drawing away, and attention a stretching toward an object. When our attention's absorbed, we often have profound unity with our bodies, like in what psychologists call the state of flow, a fluid, precise application of our knowledge or expertise just below the level of conscious awareness. Like musical improvisation, like jazz, the fluid movement between thought and action with little or nothing intervening can be pleasurable, creative, and even beautiful. The French philosopher Simone Weil, who was also a social activist, religious thinker, was one of this century's most important and original thinkers on attention, and she'll be our main interlocutor as we go forward through this talk. Her work, which was interrupted by an early death at the age of 34, consists mostly of essays, fragments of notebooks and letters, and many of them touch on the concept of attention in diverse contexts. She talks about attention in labor practices, international politics, school studies, but especially in the care of the suffering other. While her work doesn't culminate in a systematic philosophy, her slow development of the concept of attention throughout her work creates an experience in her reader through reprisals, repetition, and deepening that's not unlike the hidden curriculum of medicine. The close reader of Weil comes to understand that attention is a fundamental disposition at the root of what she sees as an authentic pursuit of the good. She wrote, "Attention is the rarest and purest form of generosity." I think this quote, which was in one of her letters to a dear friend, encapsulates a lot of what's to follow. But it's often, when it's quoted, it's often quoted without the subsequent two lines. After this, she wrote, "It's given to very few minds to notice that things and beings exist. The existence of others outside of the self, real objects towards which we can be drawn, who are independent of our abstractions and imagination, is also key to Weil's concept of attention and to our project here." And then finally, she wrote, "Since my childhood, I've not wanted anything else but to receive the complete revelation of this before dying." Here in this third part, we have both the aspirational nature of the call to attention, that the full revelation of the generosity of attention wasn't even accessible to a thinker as great as Weil. It's something she was still reaching towards. And also its immediate proximity towards existential or kind of ultimate concerns, that there's something about mortality that's evoked anytime we think about illness, even a minor illness. And for Weil, anytime she thinks about attention, that she's thinking about ultimate things. In her characteristically uncompromising voice, Weil brings us right into the gift, right into the difficulty, and right into the high stakes of true attention. The concept of attention has been undergoing something of a renaissance in contemporary thought. It's popping up a lot in articles and in books. This is just a sampling of some of the books that have been published or articles in the last few years that center on ideas around attention. And as you can see, there are cultural critics, journalists, psychoanalysts, productivity gurus, philosophers, all thinking about attention. I think this is part of an ongoing realization of its value and the threats to attention that we face. And I see this resurgence as a positive sign that we're asking important questions in lots of different domains. It's the purpose of our work here to bring those concerns and deeply grounded in a philosophy of attention to medicine. Unfortunately, it's not too hard to make the case that our attention is really fragmented in medicine. There's a high degree of multitasking, parallel processing, the complexity of information management, different modes of communication, documentation. And all of these create an environment that's often not built at the scale of the clinician or the patient. Even our well-attentioned quality improvement efforts sometimes tax the attention of clinicians with best practice advisories, screens, metrics, benchmarks. It sometimes feels like our attention becomes the glue that holds everything together in the systems and processes in which we're enmeshed. We use so often industrial metaphors to talk about healthcare, like the sterile cockpit that's often invoked in quality improvement literature. I think we need to move from that towards a more organic, dynamic, and frankly, human-centered approach to overgrow our sterile cockpit with a little more life. And this concern motivated a lot of our group's early work on attention, which aims to situate attention as a crucial resource. It's often under-recognized in clinical environments and practices. I think Dr. Baruch linked to this, this article, which was kind of an initial part in the bio. So thanks for doing that. I like the idea of attention because I think it provides a positive offering amidst the myriad critiques that we can raise about the techno-industrial bureaucratic mode of medicine. It bridges the world of health systems and interpersonal care. And I think most importantly for our purposes today, it leaves open a path for deeper, even transcendent concerns about what it means to encounter and engage suffering. I like to say that attention can speak the language of RVUs and the language of the Good Samaritan. We'll start by talking about attention in the salient environment as we practice medicine and the ways that we might clear the space for better attention by addressing human-centered design principles. Then we'll talk about the technical practice of medicine, education, diagnosis, and management, and the way that these practices can help us to cultivate the capacity for attention. And then, most importantly, we'll turn to the interpersonal domain and the ways that watchful waiting intersects with the personal and spiritual aspects of care. So, clearing the ground. Like it or not, our practice of medicine depends on the system of systems in which we practice. We might have a picturesque PowerPoint template of our shiny academic medical center, but we also know that underneath that shiny veneer is a complex and often fraught interplay between the authentic goods internal to the practice of medicine, listening, engagement, witnessing, integrity, avoidance of error, and those external goods that keep the proverbial lights on. Our institutions are beholden to the twin gods of efficiency and effectiveness we see all over in modernity. While those things aren't wrong in themselves, we as clinicians often sense that there's something missing in that totalizing approach, something maybe less efficient or demonstrably effective that still matters at the margins where true care happens. The separation from that creates some of the sense of alienation that clinicians and patients alike might feel and experience from the core work of healing. Some of the roots of the industrialization of medicine can be traced back to a movement that began around the time of Simone Weil's birth with the publication in America of Frederick Taylor's Principles of Scientific Management. These principles were intended to increase the productivity and efficiency of industrial practices, and they introduced new methods of organizing and measuring work, some of which we still use today, like time motion studies in medicine. Principles advocated standardizing tasks, diminishing worker autonomy in order to minimize human variability, error, and inefficiencies. It was first applied to the railroads, but then quickly adapted to many other fields. And in medicine, we see the seeds of Taylor's thinking in the branches of system improvement sciences that try and measure outcomes and then systematically change processes to achieve an end. This has been remarkably successful with certain narrow applications like nosocomial infections and post-surgical outcomes. But these principles have trouble grappling with more complex processes and more complex aspects of care. When we read the clinical encounter from the frame of industrial effectiveness, we emphasize questions about how to define, measure, and maximize productivity, but de-emphasize others, like the role of human variability and non-standard autonomous action in activities of care. Neil Postman went so far as to say that the principles ushered in a grand reductionism in which human life must find its meaning in machinery and technique. Weil was concerned with the ways that the alienation of industrial processes perpetuated by the relentless drive to efficiency eroded both culture and the individual worker. She went so far as quitting her job as a philosophy teacher and working in a factory between 1934 and 1935 in very dangerous conditions to kind of work side by side with the workers there. And that period of her life kind of undid her in a certain way. And it really is seen throughout the rest of her philosophy. In The Need for Roots, her longest social treatise, she describes two women making a garment, one for her own child out of love and free will, and another for an industrial process out of fear of punishment. She writes, one might imagine both women to be doing the same work at the same time and having their attention absorbed by the same technical difficulties. But the gulf between those two people is vast. Piecework, while effective from the frame of productivity, results in a quality of attention that's developed in restricted medium or removed from the world. For Vey, this results in a removal not just from the world, but from the self, from the core meaning of work in the broader community. Now, healthcare workers of today enjoy enormous levels of autonomy, compensation, and privilege compared to the factory workers of 1930s France. But I think we can still learn something important about the frame of scientific management that we've carried forward from this critique. What's at issue is the underlying ethos that motivates our approach towards systems. In medicine, the alienation that we sometimes feel as clinicians has something in common with the alienation of an uprooted worker whose work is abstracted and quantified. And now, as measurements of our work continue to gain precision and ubiquity, being able to orient those measures and critique them is more important than ever to help to try to avoid some of the reductionism that harm patient and worker well-being. And our goal is to do this from the lens of attention. So our group at the University of Colorado has been working on bridging this theoretical, philosophical approach to some systems improvement science. And I think of this work a little bit playfully, kind of holding this loosely as an application of philosophy that I think speaks really, really deeply to our work, and then is applied in various ways. So in this scoping review, we had looked at a large number of quality improvement studies that touch on ideas that are relevant to attention, like cognitive load and vigilance and multitasking, and tried to create a conceptual framework around that. And you can see the analytic framework. The purpose of these slides is not so much to get into the weeds here as to show that the analytic framework about salient environment and the IT environment and provider factors feeding into attention that feed then into clinically relevant outcomes has something akin to the philosophical framework that we started with at the beginning of the talk. And we also identified a list of a bunch of different measures that are used in neuroscience or psychology and had been used in these studies to quantify aspects of attention like vigilance, working memory, cognitive load, alarm fatigue. And again, the purpose of this is not to have a lecture on systems improvement sciences, but it's an example of what I mean by getting attention to speak the language of quality improvement, getting attention to speak the language of RVUs. Attention is a human quality. It doesn't come from our systems. It arises at the interface of encounter. And I think for me, at least, the goal of this work is to help clear the ground, to get the systems out of the way enough that we can have those attentive encounters, to make them less encumbered. So if the systems level forms the background of care, the clinical encounter, with its histories, examinations, and therapeutic plans, is the foreground. Here, the focus becomes the technical competence of the clinician and the ways that attention might facilitate applying our knowledge to particular cases. I think a question, a really reasonable question can be raised here, that is this technical attention the same kind of thing that we talk about when we talk about attending to another person? Simone Weil at least affirms that they are. She says that the development of attention in one domain, like the pursuit of technical excellence, is intimately tied to the availability of attention in other moral, ethical, interpersonal domains. So whether we're studying our textbooks on the incredible human heart, or encountering cardiac physiology in the hospital or clinic, we're training ourselves not just in the content, but in a way of thinking. Weil goes so far as to say that the development of the faculty of attention forms the real object and almost the sole interest of studies. Beyond the acquisition of discrete facts, education is concerned with developing a certain kind of thinker, one who can be seized by knowledge and drawn out of oneself. It's the difference between the clinician who can easily pass a multiple choice test, but is helpless in the clinic, and another who's on the road to discerning the wholeness of clinical situations in the messiness and contingency of the world. For Weil, the important part of study is what allows a person to move from the initial state and into the latter. When this happens in our work, I think it can be really profound. There's something almost musical about improvising with a patient, responding to the nuances of their presentation, approaching solutions with creativity, addressing the way that an illness manifests in a patient's unique circumstance. And those encounters can be transformative for the patient and the clinician alike. They're characterized, I think, in their deepest manner by drawing together technical expertise and radical presence. Iris Murdoch, the novelist and philosopher who was also a close reader of A, wrote in her essay, The Sovereignty of the Good, that the reward of attentive study is a knowledge of reality, something which my consciousness cannot take over, swallow up, deny, or make unreal. Just like in that second part of the quote that we started with, the apprehension of a real other as really other to whom my attention can be drawn is a virtue, far more than it's a core competency. Murdoch even says so. She says, studying is normally an exercise of virtue as well as of talent, and shows us a fundamental way in which virtue is related to the real world. Murdoch uses the example of learning a language or encountering a work of art as phenomena that bring about this knowledge of reality. But for many of us, I think we can think back to our initial clinical training. There's perhaps only once that we can encounter something, say end-stage liver failure in all its phenomenologic nakedness. When I was a med student or pre-med student, I hadn't had much clinical experience, and I shadowed with a palliative care team. And I remember seeing someone with end-stage liver failure for the first time and not having words for what I saw. The jaundice, the ascites, the fetor hepaticus, how quickly we tame it with abstractions and classifications, and how quickly we're taught to move towards a place of control and intervention and away from a phenomenon that fills us with awe that's not of our own making. It's not wrong, and I think it's essential to learn to classify and abstract and to intervene productively, but it's not the whole story. In clinical medicine, a lot of the catalysts that Murdoch and Vey would share that help us encounter reality come together. The beauty and fragility of the body, the hardness of affliction, the intellectual rigor of the practice, the ethical nature of the calling. These experiences help us to cultivate attention, and in so doing form a basis not only for our intellectual, but for our moral lives. Training, when undergone in the proper frame, can forge clinicians towards greater perception, sensitivity, and attention. And this is especially when it's led not by effortful will, but by desire and curiosity. They wrote, willpower, the kind that if need be makes us set our teeth and endure suffering, has practically no place in study. The intelligence can only be led by desire. The intelligence only grows and bears fruit in joy. Knowledge of the real is for both of these thinkers the fundamental ethical posture. And the ethical person avoids the abstractions that we might put in the place for the difficult and even harrowing encounter. And so it's to this sometimes harrowing encounter that we turn as we think about the role of attention in affliction. So throughout her work, Vey returns again and again to the concept of affliction. And she emphasizes its existential dimension. Affliction, she writes, in human personality is a different thing from suffering. Affliction is a device for pulverizing the soul. Affliction leaves no aspect of life untouched. It uproots and distorts. I like the schema. So Arthur Frank, who is an illness sociologist, develops the idea of chaos narratives in his work, The Wounded Storyteller. And while he uses different terminology, I think he's also really in tune with this difference between suffering and affliction. Any illness experience can create discomfort, but a chaos experience also disrupts a person's sense of narrative progression, of one thing leading meaningfully to the next in a life. And thus it interrupts some of our natural capacity for making meaning. And we often take that for granted when we're healthy. Just as affliction is an ultimate challenge to an individual's ability to make sense or meaning of experience, it also challenges the story of control and heroism that medicine often tells about itself. Frank says the chaos story presupposes lack of control, and the ill person's loss of control is complemented by medicine's inability to control the disease. What began as a symptom culminates in a crisis, where even the sufferer's voice can be lost in chaos and ambiguity. Here we have a painting by French artist Francois-Xavier Fabre of a scene from Sophocles' play Philoctetes. So Philoctetes was a character who was bit by a snake and sustained a wound to his ankle. And as a result of his wound, and as a result of what the suffering made of Philoctetes, his companions left him alone, stranded on the island of Lemnos. They couldn't stand to be near it. They couldn't stand to be undone by the affliction that they were encountering. In the story, the Greeks have to rescue a bow that's in his possession to win their war at Troy. And Odysseus on the left wants to trick Philoctetes in order to do so. He wants to deceive him. And he, similar to the companions that had stranded Philoctetes, feels this strong tension or drawing away. You can see kind of the line of tension in the painting between the wounded ankle in one corner and the pointing finger. However, Neoptolemus is moved with compassion at the sight of the suffering man. He can't bring himself to lie to him or to abandon him. And we can see in the painting this tension created, this pulling towards in the gaze between Neoptolemus and Philoctetes. It's there in that intersubjective space that something new, creative, and authentic can enter in. Arthur Frank writes, "The worst thing that medical staff can do to someone in a chaos story is to rush them to move on. The attentive capacity for listening or watchful waiting or staying in the ambiguous space of simultaneous presence and withdrawal also has important implications for care, not just in a crisis, but also in the context of disability, long-term chronic illness, psychiatric disease." The approach to chaos and the availability to the other is something that is risky. It's perilous. The basis that to put someone to listen to someone is to put oneself in his place while speaking. To put oneself in the place of someone who is corroded by affliction or in near danger of it is to annihilate oneself. Whether this annihilation is of a certain form of ego or a comfortable self-concept or even the projects that one's envisioned for oneself, it's very, very difficult, but it's very crucial. I think that it's worth lingering here for a second because so much of the work that we do brings us to brush with these moments of chaos. I think about the things that we encounter almost at a glance in the clinical space. Sometimes the chaos we encounter head on, we know it's of a patient, but very often it's something we hear in the hallway or we hear on the voice of a family member as we're calling them and giving a clinical update. This chaos, I think, is always just kind of at the gates, at the doors of what we do. And largely Simone Weil's project, especially later in her writing and life, is to explore what it means to encounter that with utmost attention. The wound, I think, as a lot of us experience, always opens in two directions. The wound touches those who touch it. And it resonates sometimes through history in the archetype of the wounded healer or in the reality that the wounds that each of us carry and encounter. For many of us within faith traditions, there's a very real sense that in whatever small ways we bring ourselves in authentically in a self-forgetting way to attend to the other, we also are attending to that other, to God. And I think in this moment of touch, as the contemporary philosopher Richard Kearney wrote about it, it's not just an intellectual technical engagement, a skepticism or analysis, but it's a drawing the divine back to the earth, the incarnate as the infinitely returning stranger who reappears every time we give or receive care. As the psalmist wrote, "For God alone my soul waits in silence, for my hope is from him." And as Weil wrote, "Absolutely unmixed attention is prayer." So I'd like to close with a thought that I think risks unsaying some of what we've already said. We've spoken a lot about clearing the ground, about cultivating the capacity for attention, for guarding and stewarding our attention as a resource, as the object of our clinical study and practice. But I'd like to propose that after all of that, it's in the willingness and availability to allow our attention to be diverted that real care actually happens. It's like in the gospel story of Jesus of Nazareth, who's on his way to cure the dying daughter of a synagogue leader who feels his power go out from him, and then, scandalizing his apostles, stops. He turns and regards the one who touched him with a loving gaze someone who is unworthy of his attention, some would say, and this throng of bodies just keeps pressing up against him. As a result, he's late, but not too late for things to then unfold in a way that rewrites what is possible. The bodies of others press up against us too, in the clinic, in the ill among our friends and families. They're the displaced in our communities. There are children asking for water in the middle of the night. There are patients, they're the patients of others who make eye contact with us as we walk across the ward. In her essay, Forms of the Implicit Love of God, Vey writes about the Good Samaritan, that his gift was actually in being able to turn aside from his task. The actions that follow are just the automatic effect of this moment of attention, she writes, an attention that's creative because it opens up a space of encounter. It's beyond our capacity as ourselves, but that's perhaps the point. Throughout Vey's work, she invites us right to this threshold, to this perilous interface between the finite and the infinite, between the act and its inspiration, seeking God not beyond or outside of experience, but right in it, in the midst, in the in-between or the meanwhile of the world. I think that Vey affirms that ethical call to engage and relieve suffering, to achieve excellence of technique, to reform the systems in which we work, and agrees that all of those things, the call to do that, will always exceed our ability to respond. But she also says that stepping into that gap is the difficult and uncertain work of the whole self. So that's what we have. I have some acknowledgements here of collaborators on this work in kind of various domains here at CU and elsewhere. And then some photo credits and things as well. But I'm happy to take some questions, and I really love to have a dialogue sort of about the ways that we think about attention, and if this sparks anything, resonates, or if there's other ways that we can take it. So thank you.
Yeah, thank you so much, Dr. Kissler, for that presentation and for really teaching us about especially the work of Simone Vey and attention. I think that phrase of attention, both speaking the language of RVUs and the Good Samaritan, is very especially thought-provoking for me. So yeah, we're gonna open it up for questions right now. Feel free to put your questions in the chat, or you can also use the raise your hand feature on Zoom, and I can call out to you. I have a question that I'd like to start out with, just as others are thinking about their questions as well. And the question I have is, I'm just wondering, in your own experience as a clinician and a clinician educator, in what ways that you've seen this like paradigm of attention just be helpful as far as teaching learners, whether that's like on the wards or in a more like structured classroom setting.
Yeah, I think there's kind of two places that I like to use it in teaching. One is in the inevitable moments of overwhelm on the wards, and when we can slow things down a little bit and say, what's going on here? Why are you feeling like there is something you're being asked to do or pulled to do that you're not capable of doing? And I think naming that is that there's sort of this infinite reserve of this attention that's called by each of our individual patients, and naming that and thinking about the ways that we can very pragmatically steward that as we're sorting tasks and as we're making choices of where to spend our time. I think sometimes that language can just be really resonant for the residents that I work with, especially the senior residents who are like really in that midst of task management and sorting. I also like to use the concept of attention when I'm teaching poetry and art. And so in our narrative medicine sessions that we do outside of the clinical environment, talking about an encounter with art or encounter with beauty as being a way of cultivating attention, and that same attention can be brought to bear in the clinical space. And so kind of I think just naming them and bringing them to awareness often is the way that I do that.
Awesome. And it looks like we have a couple of questions or a few questions in the chat. So yeah, definitely keep those coming, or feel free to raise your hand. I'll start with the first one in there from Claire. And her question is, are you familiar with the landmark AI paper that formed the groundwork for ChatGPT, which is titled "Attention is All You Need"? And if so, if you're familiar, do you have any thoughts on the attempted replication of human intelligence in AI and what this has to do with teaching computers on how to pay attention?
Yeah, that's a great question. I have not deeply read, so I'm just have a superficial familiarity with that article, and I think there's a sense. Well, I think there's a couple things. I think AI is this whole new frontier, and I think there's a lot of questions about what this is going to do. And there's ways that it's, I think, going to really profoundly influence just the technical aspects of how we go about our work, and potentially create some spaces to free up our cognitive load and our attention for witnessing and engagement. It's one of those funny things where I think in science fiction in the 50s and 60s, we always thought that robots would replace our bodies first, and be running around like the Jetsons doing our tasks. And it's looking like actually it's going to replace some of our minds first, and that it's our bodies that are irreplaceable in the clinical, in that sense of touch and that sense of presence. And so I think for me, at least, when we're talking about the attention of machines, and the attention of this interpersonal attention, I think we're talking potentially about different aspects, and that maybe there can be large language models that replicate a compassionate clinician. Who knows? Who knows what that is? But I think it's hard for me to see a time where that touch and where that true interpersonal connection isn't the place that real healing enters in.
Yeah, thanks for that question, Claire. And it seems like that response also resonates with what Barbara said in the chat as well about how, as a clinician, she started using an AI scribe, and it's helpful in some ways, but not perfect as far as helping pay attention. And then Deb also had a question in the chat as well. She said, thanks for your talk. I appreciate the focus on attention in relation to the patient, and higher beings and to systems. And how do you see the practice of attention in relation to the self, and more so, how does this cultivate an inner practice or dialogue?
Yeah, that's another great question. I feel like we could probably go around the room and see. I think that everyone here probably has some profound orientation or relationship to that question, because so much of whether it's a spiritual practice or mindfulness practice is adjacent to at least this cultivation of a form of attention, this relaxed attention in which we can experience ourselves in relationship to others or to God. I think for me, it's a helpful check-in point when we're kind of locked into that left-brained task-oriented mindset. And I think it's also a little bit about self-forgetting. I find, and this may be just me, but I find it incredibly pleasurable to be in a state of flow, where I'm working and forgetful of myself, and have just that proximity to the work or to the person that I'm with. And so I think that it's almost like there's this mindfulness in which you're sorting out and going into yourself in order to then go back out. Maybe there's this kind of reciprocity, at least for me, that part of that internality, that practice of attention, is for the sake of then that interface outside. But I think there's just so many ways, and I would love to hear if people have other thoughts on that. I think that's a really fruitful place to talk about what are our practices around attention, and how do we bring those to bear in our lives.
Yeah, we definitely welcome if people have any additional thoughts on that. And Adam also has a question, which is if you could share some narratives from your clinical practice where attention has been a powerful aspect of the care that you've provided.
Sure. Let's see. Well, I can think of one I'll think of one, and maybe some others will come to mind. So I do a lot of time on our inpatient medical oncology service. I'm as a hospitalist, not an oncologist, but we take care of the oncology patients who get admitted, and a lot of those patients, as you can imagine, are really ill, and they're admitted because things are progressing with their disease. And I had an instance where patient kind of crashed into the hospital, as sometimes happens, and there was a lot happening, and it was related to progression of metastatic pancreatic cancer, and trying to kind of reach for a last ditch saving operation. And there were 3 people in the room. So there was the patient, there was her sister, and there was her brother. And her brother was almost leaning over the bed, just had a lot of intensity, kind of intensity of bearing and a feeling. And you could see that there was a lot going on there. And the whole family was really situated in this question of, are we going to keep fighting, and how do we keep fighting? And there was a moment, I think, when I recognized that we were a little bit stuck in that frame, or stuck in that metaphor of fighting. And I just I said, let's take a step back. And what if there was another way of thinking about this question? What if there's another way of thinking about this other than fighting or not fighting? Or and her brother in particular, I think about him, just as much as the patient. His whole body softened, and he sat down on a chair. And that moment of softening, I think, for me was okay. We've hit something. There's been something going on that was really difficult and hard, and not that anything became easier for them, but it just allowed enough space to approach the questions in a different way. And so I guess I don't know if that totally answers the question, but I think of that as this moment where my attention was absorbed on a lot of different things that day. I had a lot of really acutely ill patients. I had a lot of tasks for this individual patient who was quite ill. But that moment didn't take a lot of time. It wasn't like I sat with them for an hour. And I think, I don't say that to say that, whatever, that I'm some, paragon of attentive care, because I think we all do this a lot. But just naming that that's what we're doing, that's the capacity that we're bringing to bear when we step outside of that systematic, task-focused productivity mindset, and into this space where we can actually see what's going on a bigger level. So yeah, does that kind of answer the question, Adam?
Yeah, and Adam, your question actually made me think of if I had some of my own clinical experiences where this was the case. And I'm thinking back to this past fall when I was in the pediatric ICU, and one of the kind of like rules on the pediatric settings is, at least here, is doing family-centered rounds where we'll present the patient in front of the child and the whole family, and kind of just go through everything. And I was taking care of a young patient who was very sick, and rounds would take a really long time just to talk about his case. And just in conversations with the residents I was working with, we kind of had picked up on, it just seemed to really like overwhelm the parent who was there, just kind of listing through like every single like organ system. And so I think by really turning our attention back towards the patient, and in this case the family, that kind of helped cue us into sort of asking the parent, like, to what extent do you want us to involve you in rounds? And so that was sort of a situation where there's sort of this rule, this like systematic rule of this is the way that we do things. But I think by being able to pay attention to some of those things that aren't like easily reducible, but just like some of the nonverbal cues and things like that, we're able to sort of have this conversation with the parent and actually come up with a plan where on some days she would want to be like fully involved in rounds. Other days she would just want like a quick like 1-minute summary, as opposed to just business as usual of doing the typical rounds in front of her every day. And so yeah, I appreciated that question, Adam, and made me think of a case that I had been on as well.
I love
So
that.
question.
There's so much that we
Mhm.
do that disintegrates our patients, right? Like we're constantly breaking them into breaking them into parts and naming them. I think that the attention is a moment of kind of reintegration after all the disintegration that we do, and we have to be able to do both those things with a lot of facility. It's not one or the other, and that's, I think, one of the hard things about what we do.
Yeah. Yeah, and then there's a question from Kara in the chat, and then we'll go to Dr. Collier after that. Kara said, regarding attention, I see and understand the embodied type of attention, offering of one's presence, being in a room and physically near to someone who is suffering as a type of attention. It seems to me that this type of attention may be easily crowded out by the required tasks of a typical day as a provider. And so in your framework, is there a way to also be attentive to a patient and their needs while completing the necessary patient care tasks that are not accomplished in the room with the patient, and how so?
Yeah, 100%. Thank you for that question, Kara. I think so. We actually have a systematic review under peer review right now, where we looked. I'll get to the kind of the answer to the question, but I'm going to come in from a side door maybe. Where we looked at time motion studies that have been done in the hospital, and it looks like over the period of our study for hospitalists, we spend 20 to 30% of our day in front of patients and the rest of the time away from patients. What I found interesting, though, about that is that most of the time motion studies characterized patient-facing time as good and non-patient facing time as bad. And I actually think that that's kind of a false dichotomy. I do a tremendous amount of the most important and good work for my patients that they don't see, that's not in the room in front of them. And I think that the attention that I bring to bear in just the technical aspects of being accurate and of being perceptive and of thinking deeply is also part of our role as clinicians. And sometimes that happens in quiet or outside of the patient room. So I think that that's where this link that Simone Weil and Iris Murdoch draw between technical, like attention to technical tasks and attention to difficult intellectual tasks, and a more moral, interpersonal, ethical attention comes in. Because I think actually that there's just a lot of continuity between those things. And it's part of the role of that work of clearing the ground, trying to make our work a little less interruptive, just so that we can do that better in both of those, whether we're in front of the patient or not, to really attend to what we're doing.
Awesome. Kristen?
Thanks, Angela. Mark, that was great. I really, for a long time, have wanted to read Vei's work, and this is, again, another motivation for me to do so. My question is around, again, just how to cultivate the capacity for attention in ourselves. I see on the call here, we have a pre-medical student, we have some medical students, we have a resident, right, on the call. And I liked what you said about like their study, right? Their like intense, deep work of studying the pathophysiology, right? And the organ systems, that by itself cultivates these virtues, which are habits. And that by itself is cultivating attention and helping us have a realization of the structure of reality, is what you called it, and that creates this mindset. Reminds me of the work of John Henry Newman, who said, right, the work of sort of the educational formation is to cultivate this habit of mind, right? It forms you as a person, this way of thinking. So, I mean, the students have these opportunities, right, to sort of study deeply, but I'm thinking of us as attendings, right? And so many of us, like we're not studying deeply the heart for 6 hours a day. I'm like answering emails and doing this edit and putting out this fire. So how would you, any tips that you can provide to us, maybe at the attending level or something, if you feel comfortable, like sort of more about your own practices or tips you have for various levels of learning? What can we do? Is there something else we need to be doing? Are the students doing enough, I guess is what I'm saying. Or is there something else we should be doing to sort of get there,
Yeah. Yeah. I mean, I think it's always aspirational, right? There's always more that we can, but I also think there's a sense that, at least for me in my practice, so much of my schooling and humbling, the way that I'm humbled in my attention, just comes from the patients and the phenomenon of each individual patient. Every list you inherit, every time you get sign out, and really every time we enter a room, it just comes because that's I think that's the place that it happens. You know, that's where all these things come together, the study and the interpersonal and the phenomenon, and allowing oneself to be awed, even if you've seen something 100,000 times, you know, to allow yourself to be awed, to be surprised, to laugh, to think something's funny, you know, to delight in someone. I think all of those are just as important as kind of this heavier pull of our work towards affliction. And they're just as real because they're all responses to something that's real and outside of ourselves. So I think that's where I look for it when I can, you know, and I don't always do it perfectly, for sure.
I have another question I'd like to ask, and but before I ask that, just say definitely keep the questions coming either in the chat or by raising your hands. I think you mentioned earlier on something about narrative medicine, and I know that in narrative medicine there's the concept of like close reading, and I'm wondering to what extent you see like similarities in like attention in the way Simone Weil talked about it, and the kind of like close reading that Rita Sharon talks about, as well as any potential areas of like difference between those two concepts.
Yeah, I think there's a lot of commerce between those ideas in narrative medicine. We talk a lot about this cycle of between attention, representation, and affiliation. So that we're present to things as we experience them, but often it's only in afterwards as we're representing them, whether we're writing about them or speaking about them, or even just representing them to ourselves in our own minds, that we really notice some of those things. And so our representations become a school for our attention, and our attention creates higher fidelity representations. And as we do those things and as we hone that, the idea is that you kind of spiral towards greater affiliation with your patients. And so a lot of the practices and a lot of the things that we do in narrative medicine, like parallel charting, you know, I'll have residents write a second medical record about all the things that you're not allowed to put in the, you know, that this patient reminds me of my grandfather, or this patient brought up, you know, a vulnerability that I have around, you know, or this patient made me laugh because of, you know, something they said. That representing hones their attention and vice versa. And I think close reading too, I think that we can think of our work in a lot of ways as reading well. We're receiving stories and we can abstract those stories into a review of systems, and we can be very reductive about it. Or we can listen to the shades of meaning and the things that are underneath what someone's saying, you know, the pauses, the things that are not being said, which are often just as important. And so I think that the attention that we bring to bear on our reading helps us to be better readers of the clinic and better readers of one another. And that I kind of think, and you know, this is clearly coming from my background there, but I kind of think that that's what we do as clinicians, is we try and read well, and we're constantly trying to read better. And that actual reading is one of the ways that we hone those skills.
Awesome. Well, we have a few minutes left. I just want to leave a little bit of space in case there are any last minute questions.
One thing that I often think about is when we're teaching our like M1, our first year students, everything's like checkboxed, right? Like from a curricular perspective, we're like, if you're going to do a good job, then you do this, then you do this, then you do this, then you do this. And then I think a lot of what I'm hearing from you is to do a good job is to show up in a room without assumptions and without a checkbox, and try to be present to a specific moment that's unique to that moment, that other experiences might inform that moment, but it's like a new thing that's unfolding. To what extent is our curriculum that's checkboxy a developmental step that's helpful towards attention? And to what extent does it create this false sense that if I'm going to be a really good doctor, I'm going to follow a checkbox or a checklist?
Yeah. I guess the way that I think about it is just that it is an important developmental step, but it depends so much on the clinicians who are bringing that to the students. I think we can't underestimate our responsibility as educators in modeling that this is not the whole thing. This is not the total picture. And I think that it's in that, the hidden curriculum that doesn't always have to be hidden, to teach that sometimes we have to be able to say something and also unsay it as we grow and, in our clinical maturity. And I think to model that I'm still finding things that I am, tweaking my practice or, and things like that over time. So I think being able to let your learners see you be in process and see you be discovering those moments and allowing for newness in your practice is probably the most important thing.
Oh, that's awesome. Thanks for that. I'm tomorrow I'm participating in a session on how to deliver bad news as part of our residency prep course, and I think that's definitely a message I'm gonna take away what you just said. Well, it looks like we are just about at time. So thank you so much again, Dr. Kissler, for this presentation. Wishing you and everyone else on this call a good rest of the day, and thanks for joining, everyone.
Thanks so much. Take care. Thanks again, Angela. Really, it's been fun to connect. I really appreciate the conversation. So good luck with the match.
Thank you. I appreciate it. Yeah, I'll let you know.